So hold on. ညီမရေစမယ်နော် Hopeညီမ Okay. မင်္ဂလာပါရှင် Good afternoon to everyone in Myanmar. This is the last of the series of 4 dermatology lectures and workshops, and it's been a really fantastic experience for us to be able to contribute towards the final part 2 medical student teaching in Myanmar virtually. And today, I mean, in the past 3 sessions, you have learnt about the basics of dermatology, how to approach history and examination. We've gone through common and emergency skin disease cases in adults and children by Professor Griffiths and Professor Malario. And we're really very lucky to have the 2 of the top dermatology nurses in the UK, Rebecca Penzer-Hick and Lucy Moorhead today. So Rebecca is a dermatology nurse specialist and senior clinical lecturer at the University of Hertfordshire. And she's also president of the British Dermatological Nursing Group. And alongside Rebecca, there is Lucy Moorhead. She's a great colleague as well that I have the pleasure to work with at Guy's and St. Thomas's. She's a consultant nurse, specialist in inflammatory skin disease, but also generally medical dermatology as well. She's also secretary-elect and trustee of the British Dermatological Nursing Group. And both of them came out to Myanmar in 2020 February when we conducted the first ever international dermatology meeting, and the first day being dedicated to the nurses in Myanmar. And we had about almost about 80 to 100 nurses attending the day at the University of Nursing in Yangon. So it's my great pleasure and privilege to have you both back to teach the Myanmar medical students today. So the floor is yours, Lucy and Rebecca.
Great, thank you very much, Sue, for the introduction, and Minglabar, everyone, which is the only word I remember. So Rebecca and I, over the next hour, are going to try, we're going to teach you some essential tips on skincare for common and emergency skin disease. And we've tried to make this presentation as practical as possible. And as Rebecca said, we'll be sort of switching speakers throughout. So I will kick off. So how do we maintain skin health? I think very much as nurses, we learn early on that, look, when we're caring for a patient with a skin disease, we are always caring for more than just the skin disease. And so we are looking after the holistic care of the patient. And that means that we're paying particular attention to all aspects which can ensure our patients' health. So for instance, looking after their psychological health, ensuring their sort of using health promotion in order to encourage patients with factors such as smoking and alcohol, and pain management. And again, we'll try and illustrate this as we're moving through. We obviously need to ensure that the skin is kept clean. And in the next couple of slides, again, we'll look at that in more detail, but keeping clean is often, we have to make sure that patients are not overdoing skin cleansing as well. We need to ensure that the skin is well hydrated, both internally and externally. So factors externally, such as ensuring that our patients are using appropriate amounts of emollients, but also internally in ensuring our patients' nutritional status. We look to promote an environment where the skin can heal, both immediately with the topicals and dressings that we use, but also the wider environment as well. And finally, just preventing exposure to external factors that can harm skin. So again, that could be things such as smoking or over sun exposure, at least for some people in this country, but also in terms of, you know, incorrect dressings, incorrect topicals, topicals that have sort of amounts of perfumes or preservatives in. I'm just going to move down. This is not a good start, it's sticking. There you go. So just to look a little bit more detail into how we keep our skin clean, we try to ensure or advise our patients to wash and bathe once a day. Quite a few of our patients often feel as though their skin disease might be because their skin is dirty or not clean, and therefore I quite commonly hear of patients who want to shower or wash 3 or 4 times a day. I also hear that some patients will want to shower in hot or even scalding water, because if they have an itch sensation, then they actually prefer to feel the pain from washing in hot and burning water. So again, we would advise patients to wash for 15 minutes once a day in tepid water. We advise the use of non-soap products, so that's not any perfumed products that are available in supermarkets or shops. We ask patients to use bland emollients that can be used as a soap substitute. And then once they've finished washing, we ask patients to pat dry. So that's not using an abrasive towel, but just a sort of a patting motion on the skin. In hospital settings, we try to keep washing and bathing person-centered. And by doing that, it's basically involving our patients in all decisions. So trying to ask whether they prefer a shower or a bath, what products do they wish to use, and also promote self-care as well. That can often be quite challenging, because often in my department, we will have patients arrive at our day centre and seem surprised that we're asking them to put some of their creams on. But again, it's really trying to promote autonomy within the patient. That has, I have to say, been challenging over the last year with some of our inpatients with current staffing requirements due to COVID. We try to do proactive planning, so patients who are coming into hospital, we have ways of making sure that when they're admitted, they have all the sort of things such as soaps and toothbrushes and everything else that helps, that they can use to help with washing and bathing, and also maintaining communication. So ensuring that at all times we're obtaining consent for what we're about to do with the patient, and ensuring that they are able to feel as though they are part of the process as well. And then further ongoing nursing management of the dermatology patient is we would keep ensuring that holistic assessment is at the forefront of, again, all the decisions that we make when we're caring for our patient. We try to prevent further skin injury. We try to prevent infection via, the topicals that we're using and dressings, provision of adequate nutrition and hydration, pain control. In some skin conditions, I think pain control can sometimes be overlooked, and we now have strategies in making sure that we're monitoring pain in patients and ensuring that they have adequate analgesia. Psychological support for dermatology patients is quite a sort of a hot topic in the UK. We've had a recent debate in our parliament, and it's something that we have, we're lucky at Guy's and St Thomas's to have access to psychologists, but in many centres that's not possible. But again, trying to signpost patients to avenues where they can receive psychological support if required. And finally, ensuring that we are providing the optimum skin environment for healing through use of topicals and dressings. So we're going to discuss treatments today, and the main treatments we're going to discuss are steroids and emollients, because these are the ones that are most commonly used in dermatology. So emollients are their importance in dermatology care cannot be overestimated. Regular emollients really help improve skin health and really help the impact of other systemic, other topicals that we use on the skin. So by using emollients regularly, we can decrease the dryness and cracking and soreness of plaques. We improve the symptoms of soreness and itching as well, and little tips such as putting an emollient in the fridge and applying it cool from the fridge can really help with itching. It helps soften scale, which allows other active treatments to be better absorbed. It's useful, we would always advise patients to apply an emollient whilst the skin is warm after bathing, but then we would always ask patients to sort of wait a good 30 minutes before putting on any active treatments to ensure that the emollient has been fully absorbed. Regular emollient therapy can have a steroid sparing effect, and it can be used as maintenance between active treatments as well. As we've said, some of our emollients we use as a soap substitute, as well as a leave-on emollient, and there are different products which I'll mention throughout the presentation. Again, patient preference cannot be underestimated. We're lucky enough to have a variety of emollients that we can use for our patients, and we have designed an emollient trial pack that can be given to patients so that they can take them home and decide which one they like the best. But ultimately, at the end of the day, the emollient that the patient likes is going to be one that they use. And so often I may be thinking, actually, I think you need a more greasier emollient or an ointment. But if the patient's saying to me, I prefer the cream, then it's better that they have the cream and it's something that they are going to apply regularly. And finally, we're becoming more and more aware that emollients can be a fire hazard, not only on the patient themselves, but if the emollients are absorbed into materials which are not washed properly. So we do give patients advice on that any clothes that are saturated with emollients should be washed at a high temperature, and that patients should take care around naked flames or if smoking, etc. So some good practice tips. We would advise that emollients are used per patient, so they're not shared amongst family members. For infection control, we would always advise that patients don't stick their hands in, but try to decant using a spoon or a spatula. They need to be stored appropriately, and as I said, somewhere cool with the lid firmly back on. And if they can be stored in the fridge as well, and that can be useful. As I said, if patients are feeling that their skin's very itchy, apply an emollient direct from the fridge can have a cooling sensation. If we're using any other active treatments, we would advise patients to wait 30 minutes. And we also give advice that patients should never rub moisturizers into their skin, but they should stroke it in the direction of their hair growth as well. And again, patients who are particularly hairy may find that actually a more cream-based moisturizer will be more helpful because it won't sort of occlude the hair follicles. So again, it's ensuring sort of individualized choices. One of the main barriers to effective emollient treatment is that patients are not given the correct amount. And this is a table that's copied from our pathway, so our sort of London pathway for emollients, and there was a lot of debate with this, and I think I was quite passionate that we actually did include a specific amount, because we often find that in primary care, patients have trouble having prescriptions for over 600 grams a week. So basically what you're talking about is in excess of 4 large tubs of emollient a week if a patient is using it regularly, both as a moisturizer and as a soap substitute. And again, for children to be prescribed half the amount. But patients who have severe skin disease, which is affecting large amounts of their body, will get through lots of moisturizers. So just to be aware of the quantities that need to be prescribed. I believe this has been slightly covered in earlier presentations, but just to reiterate, when we're talking about steroids, we generally want to use milder steroids on areas of the body where the skin is thin. So for instance, the face and eyelids and groin and flexures. It's on the face and eyelids. When we're going up to the groin, we may want to use moderate. And then in areas of thicker skin, we would use stronger steroids. So that's for the knees, trunk, limbs. And then for palms and soles of the feet, we would use very strong. For some of the examples I'm going to go through later on with some of the more sort of serious skin conditions, we may be stepping up to very strong right from the beginning. So for some of our blistering disorders, but this is, as a rule of thumb, the general sites that we would be looking to prescribe steroids. Again, for steroids to be effective, patients need to have the correct amounts, and they also need to apply the correct amounts too. We often refer to a fingertip unit. So that's if you squeeze out from the tube a ribbon of cream equating to the fingertip of the patient, and then you can see on the guide how many fingertips you would need to cover the whole area. Again, you have to take into account how much of that area is affected by the skin disease, but it's a useful guide. And again, so if you're thinking about 100-gram tubes, which is normally what we can dispense, if somebody is erythrodermic, you could be using 1/4 of a tube in each application. So again, it's important to remember when dispensing or prescribing medications to patients. If patients are finding the fingertip unit too confusing to understand, or it's not appropriate for their particular condition, then another phrase I would refer to is, again, making sure that the steroid is sort of glistening on the skin, so therefore it is visible. Some people can be very reluctant in my setting to use steroids longer term, or to use appropriate amounts of steroids, because there's been sort of some concerns raised that patients can withdraw from steroids, or that their skin will thin. So again, it's working with the patient to answer their questions and ensure that they are happy with the skin regime that we have prescribed. And I have to say that in some examples, our patients are completely reluctant to use steroids, and so we will look for other alternative topicals to use. But in my experience, the vast majority of patients use and can tolerate topical steroids. It's effective for their skin disease, and we can step them down and move them into a maintenance phase quite easily. But this is a sort of a useful guide for knowing how much topical steroid to prescribe at any one time. If anybody's interested in seeing very short videos on how to apply topicals, these videos are designed for patients. They're about 2 to 3 minutes long, and they're available on the YouTube channel for the British Association of Dermatologists, and they were made by myself and colleagues that I work with a couple of years ago. And I believe that the YouTube channel can translate into different languages. I have to say, I'm not sure if Burmese is one of the languages, but yes, they're 2 to 3 minutes long. They are practical demonstrations of how to apply topicals, so they may be useful to have a look at for either yourselves or for patients. But as I said, they can be found at the YouTube channel for the British Association of Dermatologists. They're all listed on there. I'm now going to hand over to Rebecca for the next section.
Thank you very much, Lucy. So it's been great fun. I've been tapping away in the chat function whilst you've been talking, Lucy. So do have a look in there and see what comments come in. And thank you everyone for interacting so much. It's really great to be able to respond to your questions directly. So I'm going to talk to you a little bit now about what happens when the skin fails. So what happens when we're confronted with chronic wounds, particularly because they tend to be the ones that are more challenging. So we define a chronic wound as a wound where the 4 key phases of healing are not happening within a normal time frame. So for one or more reasons, healing may be disrupted, and it can be disrupted at any one of those 4 different phases, whether it's the initial homeostasis, the inflammatory processes that occur after an injury to the skin, the proliferative phases where we would hope to see the knitting of the epidermis over a chronic wound, and the maturation phase where that sort of process settles down and you get integral epidermal function again. And obviously the time frame for a chronic wound will vary, but generally if we're seeing something that's not healing properly after about a month, we would probably consider that to be a chronic wound. Okay. Oh, next slide please, Lucy. I forget, I've got to ask Lucy to move the slides forward.
Sorry, just trying to do that now. There you go.
Yeah, lovely, thank you. So what are the sort of fundamental principles that we need to think about when we're thinking about managing chronic wounds? And I think a really important starting point is obviously understanding the etiology of a chronic wound. So why is this wound failing to heal? And if we don't have that understanding, and unfortunately we don't have time this morning to go into that in any detail, but just for part of your assessment process, you need to be thinking about, well, why is this wound not healing? What are the underlying reasons for slow or failed healing? For example, that may be venous disease, and certainly in the UK, that is a significant cause for chronic wounds. but for example, diabetes or lymphedema caused by whatever reason. These are some reasons why people might develop chronic wounds, often on lower limbs, and understanding that underlying etiology is really important and must be managed. But, and this is what I'm going to talk about a little bit more this morning, we also need to have the skills for actually managing the chronic wound itself. So understanding underlying etiology is important, but we also need to get a sense of, well, how do we actually manage this chronic wound? Next slide, please, Lucy. And we've developed within the UK this sort of mnemonic for helping us to think about the various different elements of assessing the wound bed. And you'll see that it spells out the word time. So we're looking to look at the tissue, infection, moisture, and the edge of the wound. So that's what I'm just going to chat through briefly this morning. Next slide, please, Lucy. So when we're looking at T, we're looking at the tissue. Is the other slides not? Oh, there we go. So we're looking at the tissue in the wound bed. And this is obviously where our eye is drawn to anyhow. So this is what we're going to be looking at. And obviously the key fundamental point here is that wounds will not heal without a healthy wound bed. And what we're looking at here are two different types of wound bed that are basically going to delay healing. So the top picture there, we have necrosis, so we have necrotic skin, and the bottom picture we've got slough, and both of those types of wound bed will basically mean that healing is delayed. And what can we do about that? How can we manage and manipulate the wound bed in order to enhance healing? And the thing that we need to think about perhaps initially is debridement of that wound bed, removing the slough or the necrosis that is slowing down healing. Next slide, please, Lucy. And there are lots of different ways that we can think about debridement. And it will depend a little bit on obviously what the wound bed looks like, but actually more importantly, it will depend on your own skills and what you have available to you to enable that debridement to take place. So the first thing on the list is an autolytic way of debriding a wound. And that basically optimizes the natural processes within the body for removing that unhelpful tissue on the wound bed. And basically that's using the body's own processes of producing wound fluid that will allow the separation of that slough or necrosis from the wound bed. And we do that through using dressings. So using dressings that maintain a degree of moisture in the wound bed that allows that separation to take place. And that's a slow process, but it is less painful. We do also have the opportunity to use enzymatic processes, and those are particular products that contain enzymes that allow that process of separation of the slough or necrosis from the wound bed. And those can be very effective and not painful, but generally are expensive. These are sort of highly developed wound products that are often quite pricey. Biological strategies for moving particularly necrotic tissue, so by using sterile larvae or maggots to remove that is also a useful strategy. Obviously you need to take into account the patient and how they feel about that, and you need to have access to sterile larvae. Mechanical abrasion, so through using dressings or gentle abrasion, can be effective but very, very painful and therefore not recommended. And then using sharp or surgical debridement can be effective, particularly with necrotic tissue, but obviously very specific skills are needed for that. And that shouldn't be something that's undertaken unless you have those abilities to use sharp debridement. Next slide, please, Lucy. So we've talked then about the tissue. Next thing we need to talk about is infection. And most chronic wounds are actually colonized. And therefore, the use of antibiotics really needs to be very judicious within chronic wound healing. And inflammation itself is obviously a normal and natural part of wound healing. So trying to make that distinction between inflammatory processes that are a part of a wound having been infected and just the normal process of wound healing is really important. The host response and the virulence of a pathogen will influence the move towards actual infection that needs the use of antibiotics. So I really just draw your attention to this fact that most chronic wounds don't actually need antibiotics to treat them, but there are obviously instances in which they are. Next slide, please, Lucy. And I just wanted to share with you this table which has come from our journal, the BDNG Journal Dermatological Nursing, which just gives some hints and tips as to what you should be looking for. So common signs of localized inflammation will of course include erythema, heat, swelling, pain and tenderness. And then all these other sort of criteria are what you need to be looking for if there's actually an active infection there that may well respond to antibiotics. So there's a number of different things there that you need to be thinking about to help you make that distinction between what's just normal inflammation and what might be an infective process where antibiotics are needed. Next slide, please, Lucy. So this is a picture to just demonstrate an instance where you may be taking a dressing down and you see this sort of greenish discoloration on a dressing, which suggests that this wound is infected with Pseudomonas. And of course, that would be an instance where you may think that antibiotics are going to be necessary. So you need to use your eyes, you need to use your nose, you need to be able to smell what's going on here. To determine that. But I think that little chart on the previous slide is a very helpful guide for that. Next slide, please, Lucy. We're now going to move on to discussing the M of, oh, sorry, no, before we do that, this is an instance, so the typical red legs. We've got two different pictures here, one of which shows cellulitis and one of which shows varicose eczema, both red legs. And one of the issues, particularly that we see in the UK, is that people don't make the distinction between the two, and they'll treat both with antibiotics when in fact actually only cellulitis needs treatment with antibiotics. So the left slide here shows cellulitis, and you can see a very distinct solid red colour with a distinct border to it. This patient may well be systemically unwell, they may well have a temperature, they may well be pyrexial, and you can see that there's a very distinct colour to that leg. There aren't many skin changes in terms of dryness, and one leg is completely clear and the other one is clearly very red. What you tend to see in varicose eczema on the right-hand slide there is skin changes. So you can see the skin dryness. You can also see that there's varicose veins in that leg, and it's often just unilateral. It'll be slow in terms of how it's developed. The patient is unlikely to be systemically unwell. So it's really important. This is a very good example of trying to make that distinction between when antibiotics are needed and when they're not. So treatment of varicose eczema will be treated primarily through the use of emollients that Lucy's already spoken about, and topical corticosteroids. Next slide, please. I think we are now going to move on to talking about moisture. So, excuse me, I just need to have a quick drink. So moisture is really important, and moisture in a wound bed is there to help wound healing. And there is quite a lot of literature to support the fact that moist wound healing is generally agreed to be desirable, and that products and dressings that facilitate moist wound healing are the best way to heal chronic wounds. But having said that, obviously too much exudate can cause skin maceration and damage to the skin barrier. So as with all things in healthcare, it's about that management of something being excessive and therefore damaging, and not having enough of it, and therefore it's not promoting that wound healing. So we want to promote moist wound healing in chronic wounds, but we don't want to have so much exudate that it's compromising the barrier. And generally wound exudates should be clear or pale yellow in colour. And we saw on that previous slide that I showed you, the wound exudate that had seeped through was green in colour. So clearly that's not what we're looking for. And wound moisture really is managed by effective dressings that allow excessive moisture to be absorbed, but allow the wound bed itself to remain moist. And sometimes what can be helpful is protecting the wound barrier, the wound margins with a barrier product. So something thick and greasy like a Vaseline type emollient, or something with zinc oxide in it, can be helpful at protecting that wound barrier, which helps to protect the skin from any excessive exudate that's coming from that chronic wound. Next slide, please, Serena. Oh, I'm saying Serena because your name's popping up on the screen. Actually, I mean Lucy. Thank you. So this is just a couple of examples where we can see that you're getting some skin maceration around a chronic wound. So on the left-hand side, where somebody's removing that wound dressing, the wound dressing itself is probably an appropriate wound dressing, and that's a hydrocolloid wound dressing, which is helping to manage some of the wound exudate, but we're still getting some maceration around the edge there, which may make the practitioner think, well, maybe I need something that's going to absorb a little bit more, for example, a foam dressing, which will have a greater ability to absorb that exudate. And on the right-hand side, we can see a heel wound, possibly a pressure ulcer wound, which is extremely macerated around the edge there. So that may well benefit from having some protection applied to it to protect that peri-wound skin. Next slide, please, Lucy. And then the edge, so we've already seen there when we were looking at the sort of the maceration that can occur, the importance of looking at the edge of a wound. And obviously wounds epithelialize from the edge. And for this to happen, it's almost like we need to think about everything else that we've already talked about to ensure that that edge can contract in and can heal, because healing usually occurs from the edges of the wound where you've got active epithelium, and that moves across the wound edge. The couple of things that you just need to look out for if you've got abnormal wound edges is overgranulation. So that's where you basically got the keratinocytes overdeveloping, but it's not actually epithelializing, and malignancy is the other thing that you need to bear in mind. So if you've got a wound edge that is not moving across the wound and it looks unusual, you should be thinking about, well, is there a malignancy here? And particularly squamous cell carcinomas can appear at the edges of long-term non-healing wounds. So can I just have the next slide, Lucy? I think I've got a picture there of overgranulation. So you can see here that you've got that sort of raspberry colour, the edges of the wounds are heaped up, and it's kind of very over red almost and shiny, and that's a typical overgranulating wound. Next slide, please. So what I'm going to just move on to now to talk to you a little bit is some hints and tips around what happens when you're managing dry skin. And it fits in very well with the stuff that Lucy's already been speaking about. And it's one of those really practical things that you need to be thinking about. So why do we get dry skin? So you may well have a dermatological condition, particularly something like eczema or ichthyosis, but it may be the overuse of skincare products that dry the skin. And we've already talked a lot about washing the skin using skincare products, and those can dry the skin, and particularly if they're overused. And if you've got dry skin, you may well have decreased barrier function and with increased transepidermal water loss. And I'm sure you'll remember from your previous lectures that intact and well-functioning barrier function is really important for preventing the penetration of allergens and infections, etc. So we really want to have a good barrier function to the skin. Next slide, please, Lucy. So you need to think about what are your strategies, and obviously you want to prevent any further drying effect, but you also want to enhance moisturization. So there's two kind of key prongs to this: preventing the skin getting any drier and enhancing moisturization. Next slide, please. So preventing further dryness, again, just reiterating what we've already said, avoiding irritants. And one of the very common irritants that people will use are wash products. So foaming, perfumed soaps are very common as irritants, and removing those is a very simple and straightforward strategy to begin with. Next slide, please, Lucy. So there are two key principles to the points of applying emollients. So just slightly repeating the messages that Lucy's already said, but two key principles of emollients. One is to occlude the skin, so by using a greasy emollient like an ointment. And I know I was answering some questions around whether Vaseline might be an effective emollient, and certainly that can act as a greasy ointment. So that's one of the principles of using emollients. And the second is increasing skin hydration through a humectant effect. So some emollient products will contain humectants, so products, so things like urea or glycerin, and they are actively rehydrating the epidermis. So both of those mechanisms are useful for when we come to talking about emollients. Should be applied frequently. Great to apply them after bathing when the skin is slightly damp, particularly if you've got an occlusive emollient, because that traps moisture next to the skin. And as Lucy's already said, apply gently rather than rubbing vigorously. Next slide, please. Emollients may have some side effects uncommonly, but they can be irritant. The patient may think that they're messy. Lucy's already talked about the fire risk, particularly if they're soaked into a fabric, when they can become like a wick. Obviously they can make things slippery. I think in hotter climates, something that you do need to think about, particularly if you're using very greasy, thick emollients in babies, that it can make it difficult for babies to regulate their temperature, because they occlude and keep the heat trapped next to the skin. So I think particularly in hotter climates, that's something to think about. And folliculitis, particularly again with the greasy emollients, which we've already heard about. Next slide, please. I'm handing back to Lucy now. She's going to talk about physiology, so I'll take over the questions.
Brilliant. Sorry about the delay in slides. I can't answer questions and move slides on at the same time. So next we're going to talk about scaling, and this is a commonly seen in many skin conditions. So just a sort of bit of physiology. So skin diseases that have excessive scale or flaking are normally referred to as papillosquamous disorders, and they're due to epidermal inflammation or proliferation. So too many cells on the surface, and they're a clinical manifestation of stratum corneum disease, and as I said, indicate inadequate or flawed keratinization, and the picture below is a very typical plaque of psoriasis. So examples of skin conditions that present with scale, and this is not exhaustive, but are conditions such as psoriasis, ichthyosis, dermatitis, seborrheic dermatitis, some tinea infections, crusted scabies, which we'll be talking about in a bit, cutaneous T-cell lymphoma, which can often in early stages be mistaken for eczema or psoriasis, and also dermatitis neglecta. Going to start off talking about scalp treatment. This is one of the sort of commonest things that I would be treating in my day unit. It's normally effectively treated with topicals. The picture below shows a sort of a typical scalp affected with psoriasis with quite thick scale. And in order to treat a scalp like this effectively, you need to use a number of products in the correct order. So just prescribing one product is unlikely to be effective, and in fact is not going to be effective. And again, quite often I will see patients who've been referred to us who perhaps have been prescribed one product, it hasn't worked, prescribed a second product, it hasn't worked, prescribed a third product, it hasn't worked. But if they'd all been used together in the correct order and shown how to apply appropriately, then it would be effective. So with a scalp such as the one below, firstly, you need to soften the scale. We would normally prescribe either a keratolytic product such as Sebco or a very greasy emollient such as hydromol. And we would apply this direct to the scalp in order to soften the scale with occlusion. The one thing that struck me when I visited Myanmar was how all the ladies had this wonderful long thick hair, which is not typical of the patients that I see in our unit. So I am aware that perhaps the sort of scalp regimes that we would use perhaps on somebody who has short hair might be a lot more challenging in people with longer hair. But generally you'd need to use a product to begin with first off, apply it directly to the scalp, occlude the scalp, so wrap the scalp in either a shower cap or actually just cling film, leave it for an hour or overnight if it's a moisturizer. Then the next morning they can wash that off with a medicated shampoo. Some of the popular products we use are Alpha-Sil shampoo and tea gel. Some patients will complain that actually some of the products we're using are quite smelly. So I would then say if people want to apply conditioner to the tips of their hair, that's fine as well and gives a more cosmetically acceptable finish. And then we would use an active steroid preparation. I generally at the moment prefer either a lotion-based product, and we have one that's a Betnovate lotion, or a foam-based product as well, because they're more easily absorbed into the scalp. We have some scalp treatments and some scalp preparations that are specifically designed for the scalp, but quite often they have an alcohol base in them. And I find that they can be quite irritant or sore to patients who have any sort of broken skin on their scalp. So I tend to go towards either lotions or the foams. I've already mentioned my video, or not my video, but the BAD's scalp psoriasis video. So that shows you how to apply scalp treatment. So it is about using the products in the correct order and applying them directly to the scalp as well, which can be quite difficult to do to yourself. But generally the mainstays would be to soften the scale, and that either can be done by 1 or 2 products, depending on the amount of scale, using an active shampoo or a medicated shampoo, and then using a steroid base as well. We do have steroid shampoos which can also be used. I tend to sort of use them only in patients who are very time poor, so aren't able to sort of do the rest of the regime, because I often find that at least the patients I see, they have an amount of scale, and that really does need to be softened before you treat with the active steroids. And one of the things we've developed, which I've found quite useful, and I wouldn't do this for all patients, but just for patients for whom I am prescribing sort of a variety of products, is we do complete a treatment at home plan, and this just allows the patient to have that information written down at home so they know which product they're using where and how often. And if again this is too daunting for patients, I would then just complete a sort of a day planner, so literally list the hours and say 8 o'clock get up, put your moisturizer on, 9 o'clock put your steroid on, etc., just so that they have a guide when they get to home, because often you see patients leaving dermatology departments with a shopping bag full of treatments, and when they get home they've all got very similar names and they're not sure what to apply when or for how long, etc. Treatment plans are also quite useful if you're prescribing topical steroids, because they allow you to give weaning instructions as well, and I think that definitely helps ensure that the area is effectively treated if you don't start a topical steroid and then just abruptly stop it, but slowly wean it down. So for instance, when the skin's clear, move on to alternate days, and then perhaps use weekend therapy for a couple of weekends as well, and that can ensure effective treatment. And some of our topical treatments now, so we have a foam that's designed for psoriasis, which has a vitamin D agent and a steroid agent in it, and patients can now use that twice a week up to a year, and that just helps ensure that patients are having an effective maintenance treatment as well. If patients present with marked scale on their body, again, we would use a very greasy emollient. So I think people have mentioned Vaseline, so 50-50 hydromol, and really making sure that that's applied regularly to sort of soften the scale. We have some emollients with added urea, and as long as they're not irritant to patients, they can also be used. We have one called Balneum Plus, which is 5% urea in. If patients have very isolated plaque such as this, you can use a steroid preparation with added salicylic acid, and then occlude with a hydrocolloid dressing. And again, they can leave that dressing in place for sort of 24 to 48 hours, and they can use that for say 2 weeks, and that can also be effective treatment. So again, it's sort of softening. With this sort of plaque, you need to ensure that you are using agents to soften the scale. So that is, as I said, greasy emollients, emollients with added urea, strong steroids, and strong steroids with added salicylic acid in as well, just to help break down the scale. And again, if you were putting the steroid on, you would put the emollient on and then wait at least an hour before putting on the steroid and occluding it. I say at least an hour. It's probably 30 minutes to an hour until the emollient sort of absorbed well into the skin. We're big fans of emollient soaks. So if we have scale on hands and feet, we often find that using a greasy emollient dissolved into a bowl of warm water, so tepid water, and soaking patients' hands or feet for 10 to 15 minutes can also be very effective and a simple thing to do. So what we would do is, you can see on the top picture, is we would decant a sort of a reasonable amount of the emollient, pop it into a pot, sort of dissolve it with warm water, and then add it to a larger bowl and ask the patient to soak their hands for 10 to 15 minutes. If you're treating hands and feet, you can then apply steroids and then occlude further with either cotton or plastic gloves and socks. Sometimes we use cling film on the soles of the feet as well, but I'm always wary that that could be a slip hazard for patients. So I would say, if you know you're going to sit and watch a television program for an hour, you could do that, watch a television program, and then take the cling film off your feet if that helps. But that can be an effective way of further breaking down sort of thick scale on the soles of feet and palms of your hand as well. This is a patient that I treated with Palmar plantar psoriasis. So again, we use the emollient soaks as I described on the other page. We started off with a 50-50, so a 50% white soft paraffin, 50% yellow soft paraffin initially, and then as we built up his tolerance, we used an emollient with 25% urea, and then we use special products. So these are products that are made by our pharmacy, which are again hugely effective at treating a sort of scale on hands and palms and soles. So one particular mix is propylene glycol with Dermavate cream. So that means it's very, very greasy, so it absorbs well into thick areas of skin. And then another special product is a salicylic acid with propylene glycol and Dermavate. So again, you've got that strong steroid for the thick skin, but you've also got the salicylic acid to help break down scale. This particular patient was challenging because he was actually in and out of sections for mental health issues, and he wasn't very good at putting on any treatments at home. So we would get to a certain point with him coming to the day centre, we wouldn't see him for a bit and he'd come back. And actually one of the questions that our pharmacist asked us was, when should we consider salicylate levels? Because this patient had been using products with salicylic acid for a prolonged period of time. So we did check them, and that's always something that I will keep at the back of my mind, that if patients have been using products containing salicylic acid for a long time, we would consider a salicylate level just to check there's no systemic absorption. And I have to hold my hands up and say this, in this particular patient, we did eventually start a biologic. So we started Stelara, which is an IL-12 and 23 monoclonal antibody, in order for this patient to achieve sort of full clearance. And actually he is fully clear on Stelara at the moment. I'm going to hand back to Rebecca now for itchy skin.
Thanks, Lucy, and apologies, I didn't switch my microphone off there for a bit, so you probably heard me coughing. So why and when does skin itch? So itch is a very common side effect of skin problems, and a really distressing one for patients. So dry skin conditions, and particularly eczema, atopic eczema in particular, tend to be very itchy, but other skin conditions may have an itchy phase. So bullous pemphigoid, for example, blistering condition, can be preceded by an itchy rash. We also, of course, need to be very much aware that general systemic disease may make the skin itch. So is there something internally that's going on? It's not actually a dermatological condition, but it is making the skin itch. And obviously there are conditions where histamine is released, and that obviously makes the skin very itchy. So things like urticaria. Next slide, please, Lucy. So the first, obviously, rule of itchy skin is that you need to undertake a very clear and careful assessment to establish the cause. If there's a systemic cause, or you suspect a systemic cause, you need to do a blood workup, and the underlying condition obviously needs to be treated. So as I'm sure has been outlined to you throughout all this series of lectures, assessment is absolutely critical so that you understand what you're looking at. Okay, next slide, please, Lucy. This is an urticaria, and obviously you will need to use antihistamines to treat urticaria. I do just think it's worth making the point here that generally antihistamines are not useful in the treatment of atopic eczema, even though it's a very itchy condition. There are other processes that are going on that are causing the itch rather than histamine release. Antihistamines may be helpful for their sedative effect used at night, but beyond that, generally not that helpful in atopic eczema. Next slide, please. But eczema is a very itchy condition, as we can see here for this child who's having a really good scratch. And these are just the principles that we've already started to talk to you very much about today. So the kind of key principles of eczema management, which is a common itchy condition, avoiding irritants, using your topical emollients that we've talked about, using topical steroids for 7 to 10 days. We've talked about 2 weeks. It's a movable feast. It is flexible, and it will depend a bit on disease severity, where the eczema is. But we need to look at those, the time frame, and reducing the dose. And again, I talked a bit about that in the chat, to alternate days before stopping the use of topical steroids. So topical steroids become problematic when they're used on an ongoing basis, used as what we would say pulsing them. So using them when you get disease flare up like this, and using them for a block of time is safe for patients to do. But if they're continually used on an ongoing basis, that's when we start to have issues. Next slide, please, Lucy. So what are some other helpful strategies that might help with itchy skin? Heat is something that generally drives itchy skin. So keeping cool is a good strategy. Trying not to scratch, and again, particularly if you're talking about children with itchy skin, they often scratch in moments when they're not being distracted by other things. So using play, for example, to distract them, or if you're talking about adults, often adults will report that, you know, if they're doing something, they don't scratch so much, but when they're just sitting watching television or not doing anything, that's when they start to scratch. Occlusive bandaging or wet wrapping, where you use damp cotton bandages next to the skin, that can help to cool the skin and therefore make it less itchy. Emollients with menthol. So menthol is great at kind of making the skin cold and feel chilled. Lucy's spoken about putting emollients in a fridge so that cools it down. It's all the same sort of process that we're looking at keeping the skin cooler. And UVB can sometimes be helpful for the treatment of chronic intractable itch, particularly in conditions like nodular prurigo. Next slide, please, Lucy. I can see you've got lots of questions to answer as well. Oh, and it's back to you. So I'm taking over the questions.
Great, thank you. So going to move on now to talk about blisters. So blisters are essentially small pockets of fluid or large pockets of fluid under the skin. If we're talking about small blisters, so blisters measuring less than 5 millimeters, we're generally talking, we call them vesicles, and this can be seen in Pomflex eczema, varicella zoster, and eczema hepaticum. I'm going to be talking now more about blisters that occur with conditions such as bullous pemphigoid, bullous drug eruptions, and allergic reactions. So bullous pemphigoid, with blisters in bullous pemphigoid are subepidermal, so therefore they will appear more tense and will be more sort of visible and more likely to be intact on the skin. They can be very, very uncomfortable for patients. And there's a sort of a debate because patients obviously feel that they would be more comfortable if the blisters were pierced, but actually that can increase infection risk. So we will pierce blisters if needs be, but try to keep them intact where possible. So I just thought it'd be useful to run through how to aspirate a blister. Obviously, before aspirating a blister, you'd kind of explain to the patient what you're doing. And then with a clean needle, you would ensure that the bevel of the needle is facing upwards. You'd pierce the blister at the base and use a gauze pad and gently apply pressure to the blister in order to allow fluid to drain. And then finally at the end we just normally dab a tiny bit of dermal 500, which is an emollient with an antimicrobial added, just to kind of help reduce any infection risks. And I don't know where this picture has come from, but it's been around in our unit for many, many years. But this is an example of how not to aspirate a blister. So the problems with this picture is that the bevel of the needle is facing upwards. You're piercing at the top of the blister, and you're also aspirating fluid. And to do this is more likely to cause your patient pain and discomfort. And we also wouldn't sort of remove the tops of blisters either. We would always, try to pierce at the bottom and use gravity to allow the blister to drain. In pemphigus patients, the blisters are more fragile and flaccid, and so often you won't ever see an intact blister present on your patient. This is a very painful condition for patients, and pain management needs to be considered. And it can also be in terms of in an inpatient environment, dermatology patients such as these can be very consuming to wash and dress on both a medical ward and an ITU environment. And Sue and I have both been involved in a patient at the moment who's been in our hospital for a number of months. And as I said, staffing has been challenging over the last couple of months. And actually we've had to sort of bring over dermatology nurses to daily visit the patient to ensure that the patient is washed and dressed appropriately, and it has been quite a challenging situation. In terms of topical treatments that we use on patients such as these, as we've said, we would use a soap substitute for washing. We would use potassium permanganate solutions if there's anything that needs to be, if the condition is wet or weepy and perhaps we need something to sort of dry it up. Regular emollients would be used, and again these would be the very greasy ones ideally. There is another emollient called Emollient spray, which can be sometimes if you're nursing a patient in an inpatient environment and you're using lots of greasy topicals, they can almost saturate and pool on the skin, and in which case we would reduce the amount of very greasy emollient and perhaps use a lighter spray just to kind of ensure the patient's comfortable. With these type of conditions, you're going to be using sort of very potent steroids such as Dermavate, and we also use non-adhesive dressings both to the lesions and would nurse the patient as a whole on a sort of a large non-adhesive dressing, which we sort of cover with 50-50, and that's got a name of Exudry, but it's a sort of a very large non-adhesive dressing that the patient would lie on. This is an example of an inpatient skincare plan for a patient with pemphigus. As I said, we would we would aim to wash the patient daily, and we would use an octenison, so an antimicrobial wash product. Directly after washing the patient, we would apply emollients. We would then wait for an hour and apply the sort of relevant topical steroids. We would then use non-adhesive dressings to areas which required them, so where there's eroded or broken skin, use a second dressing and a further dressing to secure, and then nurse the patient on as I said, this one-piece non-adherent wound dressing, which is buttered with emollient. So really trying to ensure that the skin has minimal trauma. We would also be very wary of how lines and catheters are secured. Again, you wouldn't want anything directly using anything or tape, etc., to secure to the skin, as well as this might increase skin damage to those areas. If a patient is bedbound and we're unable to sort of move them to a bath type area, we would still want to use the octenison, but what we would try to do is saturate soft wipes or sterile gauzes in undiluted octenison, and we would sort of lay them onto the skin for no longer than 4 minutes and then gently remove and rinse them off with warm water. And we would wash the body in sections as you would do normally as well. The octenison would be washed off with warm water, so you'd either use gauze swabs or perhaps a sort of a catheter tip syringe as well. And again, you would be wanting to apply the skin, you would want to pat dry the skin very, very gently. If you have a patient that you can get into the bath, you can use a hydromel balls, or sorry, an emollient ball. So that's a greasy emollient, a sort of a lump of greasy emollient wrapped in a sort of a bandage, and then it's allowed to disperse into the bath. We do not use bath oils, and we don't use other antimicrobial dermal 500. So that was the emollient I mentioned earlier, which has antimicrobial properties, as that can sometimes irritate the skin when used as a soap substitute. And in the picture I've just shown as well, we would also want to ensure that we were protecting the surrounding skin as well, particularly in areas such as the buttocks. So we'd want to be thinking about pressure areas and using products, sort of barrier products, to ensure that, again, we minimize further damage and also minimize risk of infection as well. With any sort of blistering patient, if their mouth is infected, we will want to ensure that they have routine mouth care, and also that they are having an adequate oral intake, and that we're supplementing it by other means. If that's not possible, we would refer to the dietitians in this situation as well. And we would ensure that the patient has appropriate analgesia. So some of the products we use are sort of Difflam spray. We have a special mix which contains a steroid and sort of antibiotic and antifungal medications. We have another product that is called Gel Claire, which you apply 30 minutes before eating, and that can be very effective. And finally, we have a mouthwash that's called cocaine mouthwash, but any patient that is using that needs to be able to spit it out. But again, it just helps them maintain oral intake and also manage pain as well. I mentioned at the beginning that pain is very important to be managed. We don't have any sort of fancy scoring systems. We will just literally ask a patient to grade their pain from 0 to 10, 0 being no pain and 10 being the worst pain imaginable, and we would ensure that this is done and recorded on a regular basis. Often with patients, particularly with blistering conditions, you're already going to start at step 2, and we would make sure that anybody using codeine is not taking paracetamol as well. But as I said, these patients, as you can see, are often very sick, and they will often need morphine derivatives, and something at the moment that we've used with quite good effect are sort of fentanyl patches and lozenges as well. But the WHO analgesic ladder is actually something that we'd use across the board in outpatient settings with our hidradenitis suppurativa patients, and we'd kind of ask primary care to help manage their pain according to this ladder, as well as using it in an inpatient setting as well. And finally, a lot of these patients will be on high dose systemic steroids. And whereas we often think about adrenal suppression in patients who are using high dose systemic steroids, often particular patients who have been nursed in ITU or medical settings, it's just making sure we think about sleep deprivation actually at home as well, and sort of, asking them about their sleep. Are they getting enough? And kind of trying to give them tips to help manage that. And also just bearing at the back of their mind that systemic corticosteroids, particularly when given in high doses, can be linked to psychiatric reactions as well. So again, just keeping that at the back of your mind when caring for the mental health of your patient. Rebecca, shall I hand over to you for?
Yeah, thank you. Yeah, thank you, Lucy. I hope everyone's okay. We're going to probably overrun by about 10 minutes, so please do feel free to go if you need to. And Lucy, Harley had a question about analgesia and mouth care, which I wasn't quite sure I could answer particularly well. So if you could find that question, that would be great.
Sure.
So thought we'd just finish off with some words about scabies. this is probably possibly something you're very familiar with, but we just wanted to kind of give you some practical tips and hints about managing scabies. So, you know, obviously this is a condition, a very itchy condition that is caused by a mite called Sarcoptes scabii, and it can affect all age groups, although you probably would see it more commonly in the very young and the elderly. And the scabies mite burrows into the skin where she lays her eggs, and it's transmitted by close personal contact, although sometimes it can be transmitted by shared bedding and towels. Next slide, please, Lucy. I know you're busy answering questions. You're multitasking very well. So the symptoms, obviously, that you want to be looking out for when you're oops, I've just done something strange there. The symptoms you want to be looking out for if you suspect scabies, the presentation is looking out for the burrows, which you will often find in these areas between fingers and toes, wrists and palms, ankles and soles, groin and breast. And these are very typical presentations. So a little dot followed by a wiggly line, which represents the burrow as the mite burrows into the skin. Next slide, please, Lucy. And the symptoms clearly are intensely itchy. So I didn't mention scabies in my itch section because I knew we were going to talk about it afterwards, but clearly if you have a very itchy patient, scabies ought to be something that's in your mind as a possible diagnosis. It's often more itchy at night, and you'll get these, as I say, small red dots on the skin and scratch marks as well, because people are being driven so mad by the itching. There may be some pustules developing, as you can see in this top slide, because a skin infection has occurred, and it's not uncommon to get this sort of overarching generalized eczema. Lucy, over to you for treatments.
Great, so thank you. So generally, the mainstays of treatment would be permethrin cream and ivermectin. For us, we would normally use permethrin as a as a first line treatment, and you would apply topically to the entire body, leave for 8 to 14 hours, and then repeat 7 days later. And then there's variation for crusted or Norwegian scabies, which is that you would use it daily for 7 days. We use ivermectin in combination with permethrin for certain more vulnerable groups, and the doses are written below. Sulfur ointment is listed as a treatment, but actually that's something I have to say that I'm not familiar with using, to be honest. But yeah, so the ivermectin doses, if it's normal scabies, it's 2 doses 1 week apart, and then the Norwegian scabies, there's 3 or 5 or 7 doses depending on the severity. And then just to say, if we do in a combination with ivermectin, we would use the 5-dose regimen. And then we just had some top tips. So obviously, if you are treated scabies, you need to ensure that everyone who is affected is treated at the same time. And whilst you're treating, that all bedding and clothing and soft furnishings, etc., are all treated as well. So that they should be washed at a high temperature or sealed in a plastic bag for a week or for at least 1 week, or put in the freezer as well. A little tip, or something that people often have forgotten to be told, is don't wash permethrin off your hands. So if you're applying permethrin and you need it to be on for 8 to 14 hours, and you've been to the bathroom or you've needed to wash your hands, you need to apply permethrin. Obviously avoid sexual contact during the treatment period, and also if scabies has been transmitted via sexual contact, it's worth considering an STD screen. And finally, Rebecca and I would like to offer everyone free membership to the British Dermatological Nursing Group. We have our website, which is bdng.org.uk, but if you follow the instructions here and add the code BURMA0122, you will gain free membership for a year. And on our website, we have a number of e-learning modules and podcasts and educational materials, which we thought people may find interesting. So you're welcome to join if that would be useful. Rebecca, do you want to say anything else about? But
No, I think just yes, please do consider joining. You also get access to our quarterly journal, which is really definitely worth having. It you can read it electronically and have access to back copies as well. So yeah, we would be delighted if you could join the organisation, and as I say, that will be free to you for the coming year.
great. And I think
Well,
that's it. So we're happy to take questions. Sorry, so was that?
no, I just want to thank the both of you. Absolutely fantastic, and that was a very generous gesture from BDNG, and the both of you. So very grateful. And also, you know, those who are not able to attend today's session for whatever reason, presumably they can have the code should they wish to join as well. So do spread the news to your friends and colleagues who are unable to attend today's lecture. No, that was really fabulous. If you are, well, yes, and also a message from Professor Griffiths, of course, thanking the both of you for such an excellent and highly practical lecture, and also to the BDNG as well. There are a few sort of, I mean, you've been so efficient at answering questions, and I'm being sort of jumping in on the occasional ones. So thank you both for that as well. There are a few sort of just a couple of comments from me, and also a couple of questions if there is time for another 5 minutes. So of course, you know, it's really important for the students to learn about the variety of lotions, you know, emollients, creams, and ointments that we have the privilege to use. But as you saw in Burma as well, as you said as well, you know, there are very limited choices, and as you know, Vaseline is the mainstay of emollients that they tend to use. And also we saw at the Yangon General Hospital, they use Torpilin to manage some of the patients with pemphigus, you know, just so that they, as they don't have exudry sheets, as you know. So I wondered whether you had any comments about that. And also they do use quite a lot of coconut oil to, you know, as moisturizer for the hair, even if they don't have any skin conditions. So that's another mainstay. So I just wondered whether you may have some advice on whether they could be good replacements, replacement products, if they don't have the usual product range that we mentioned.
I think coconut oil is something that actually we use. I didn't mention it, but yeah, I mean, a lot of patients, coconut oil has become very trendy over here for cooking and using as an emollient. So yeah, absolutely, coconut oil could be used in order to soften scale and as a, and you know, as with an emollient as well, but just to make sure that there's nothing irritant in there to the skin. That's all I'd say. But yeah, I mean, absolutely, I think, you know, with the tarpauling as well, it's what you want to avoid is anything sticking to the skin. So, and that you would run the risk with that with cotton sheets. So I think that's that's the, you know, if that helps, if that means that something, sorry, is not sticking to the skin, then that's the best way to go ahead.
Yeah, no,
And
absolutely.
I think the whole the Vaseline thing, you know, it's petrolatum, which at the end of the day is the basis for most of the fancier emollients that we would use. So I think if that is all that's available, it's actually, you know, it's fine. And I think that that is a good emollient to be using. It's thick and it's greasy and it's protective as well. Yeah,
absolutely. And there was one question which was buried amongst several by Serena, I think, saying that, you know, how long do you tend to give each product to work, and when do you decide to switch? But that's a sort of a complex question to answer, but
how long's a
I'll
piece
put
of
it out
string?
there. Yeah, exactly.
Yeah. It also depends how sorry, Rebecca.
No, go ahead.
I was going to say, you know, it depends in what setting as well, because I think quite often if somebody's seen in an outpatient setting, they may not get in touch with us. You know, we're lucky enough that we try to, at least all the patients I come into contact with, I can give them a phone number. So if they're not happy with something, then we would ask them to use it. But generally, guidance for topical medications is around 4 weeks, as long as then, in order to see whether it's effective. But if it's not tolerated, then obviously you wouldn't want to continue using it for 4 weeks.
No,
I
absolutely.
think the only thing I would add to that is that is one of patient expectations. So using topical products on the skin often isn't quick. It may take longer than the first couple of applications for it to work. So I think one of the things I would struggle with patients is just getting them to give it time. So, don't give up too quickly, I suppose is what I'm saying as well, is that, you need that perseverance to, and patients need to know what to expect. And that's something you can really help them with, is that you tell them this isn't like an oral medication where you'll see an effect in 2 days. You may need to give it a bit longer.
And the last question was about how often do you change the burn dressings? How do you manage the burn wounds?
Lucy, have you got anything to add to? I mean,
yeah.
burns isn't something that I treat.
No, we don't treat either. So all our burns would be treated by a plastics team. So yes, sorry, I did.
There are general principles around, again, the same sorts of things that Lucy spoke about with bullous pemphigoid, about trying to make sure that dressings don't stick and that dressings aren't changed over frequently, because that can end up removing epithelial tissue that's developing. But also, obviously, you need to change them frequently enough to prevent infection and all that sort of thing. But Joe, I think that was a question from you. I'm sorry, or maybe it was Harley. Sorry. We're not the experts on burns, I'm afraid.
But absolutely, I agree. There are general principles, if there's full thickness burns or, superficial burns. And of course, a lot of patients that we see with toxic epidermal necrolysis or pemphigus vulgaris with, extensive erosion. So the patient that Lucy mentioned, who have been on the wards for several months, of course, we do have to apply some of the principles of managing the burns patients. So yes, exactly. It's about enhancing wound healing, preventing infection, and also ensuring that, the fragile skin doesn't break further by using non-adherent dressings. That's sort of those principles. Thank you so much. I think we'll call it a day, and thank you all very much for coming along, and thanks especially to the NUG, Dr. San Wu and Xia Dekugu for giving us the opportunity to teach dermatology to the students, and special thanks to Rebecca, Lucy, and also, of course, Professor Grace Griffiths and Professor Malario as well. Thank you all very much. And last one, would you be happy for the slides, for the recorded video to be uploaded on the YouTube channel just for the students? Thank you. Thank you all. Have a good day. Bye-bye.
Thank you, everyone.
Bye.
Bye. Bye.